This is a technique video on preventing tunnel overlap in revision ACL reconstruction through creation of a single anatomic oval femoral tunnel. To begin, the patient is positioned supine and sterile draping is performed. Standard anterolateral and anteromedial portal is made and diagnostic arthroscopy is performed. Graft harvest is done and prepared. Once a surgeon visualizes the ACL stump from the initial ACL reconstruction, debridement of the remnant ACL is done. The femoral tunnel location is then identified. To proceed with a new femoral tunnel preparation, a footprint marking hook is used to plan the placement of the new bone tunnel, which in this case is noted to be inferior and proximal to the old tunnel. The drill sleeve is inserted 60 degrees to a line perpendicular to the femoral anatomic axis and 20 degrees to the transepicondylar axis, and a 3.5 mm flip cutter is then passed from the lateral cortex of the femur towards the lateral wall of the intercondylar notch, ensuring that it is exiting at the right point. Once inside the joint, the flip cutter is opened and a larger diameter tunnel is reamed in a retrograde fashion. This now produces the initial hole. After the initial hole is made, the flip cutter is then tilted to make the oval tunnel. This is done by carefully tilting so the step drill sleeve points more inferior and distal. The hole produced with this motion will now become the new oval femoral tunnel. Tibial tunnel is then made accordingly and graft is passed. In creating the oval tunnel, we first measure the diameter of the graft bundle, which we identify as capital G. We then calculate its corresponding graft cross-sectional area using the formula shown in the screen. Using this formula, we have this table which lists the different calculated graft cross-sectional areas for each corresponding graft bundle measurement. Next step is to determine which drill diameter to use, which we identify as capital D, and how much to tilt it to make an oval tunnel. The drill is only tilted in one direction, and thus the minor axis is equivalent to the drill diameter. For every major axis, which we identify as capital D dash, the corresponding oval cross-sectional area is calculated using the formula shown on the screen. Using this formula, we have this other table which lists the different calculated oval cross-sectional area for each corresponding drill diameter. And using these two tables, we can now identify the appropriate drill diameter to use and how much to tilt the drill to make an oval tunnel. We do this by first identifying our graft size and its corresponding graft cross-sectional area. We must then select an oval cross-sectional area that is slightly larger than this value. This is to ensure that the graft would fit into the oval tunnel. The oval cross-sectional area will then have a corresponding drill diameter and a major axis. This would then mean that for a graft diameter of 7, we use a size 5 drill diameter and tilt it just enough to make a major axis of 10. It is also noted that we can also choose this other oval cross-sectional area because it is also larger than the graft cross-sectional area. However, this would be too big and be too loose in the tunnel. Let's have another example in which you have a graft size of 8 with a corresponding cross-sectional area of 50. We have these two cross-sectional areas that are larger than this value. However, choosing which drill diameter to use would depend on the space left in the lateral wall of the intercondylar notch. If there is less space, we choose 5, but if there is more space, we choose 6. Tunnel management plays a crucial part in revision ACL reconstruction, especially because of the already existing tunnel. The most distinctive feature of our technique is that by making the new tunnel in an oval shape, overlap with the old tunnel is avoided while still creating an adequately sized tunnel within the anatomic footprint.